today I'll be talking about harm reduction from a public health perspective. In fact, the idea of harm reduction came from public health. So, and also very specifically in the context of the rapid spread of HIV infection and drug use related HIV infection. This is one of the disease impetus for looking at the efficacy of harm reduction. So, and also there are certain historical facts behind how harm reduction evolved. If you look at the issue of alcohol control, about 100 years ago, the complete prohibition was implemented in the United States. Now it's exactly 100 years this year. So there are photos of historical photos. We can see complete destruction of alcohol, huge vats, huge tract of alcohol pools are created. So there's a history of how drugs, how alcohol, how mind-altering substances are regulated and controlled. So that's one of the facts you have to remember. So when we look at harm reduction, the idea of harm reduction is a set of policies, set of programs, and also a set of actual pragmatic ideas. How do you regulate substance use? The emphasis is not on complete prevention. It's about regulating, and also it's about reducing the risk related with the use of drugs. And also you are looking at what are the legal implications and how laws are created. And when you look at harm reduction, quite often it's at the gray areas of legal implementation. And also, just an introduction, I wanted to share my experience of running harm reduction programs. I worked in Manipur, Churasanpur district for 2 years, implementing a harm reduction program. That's one of the first harm reduction projects in the country, looking at the efficacy of behavioral modification for reducing HIV infection among the injection drug users. So the idea is not completely banning the drug use. It's not about completely looking at the legal aspects of drug use, but whereas reducing the harm-related drug use. And our program was to distribute syringe and needle and related paraphernalia to the drug users. And probably that is the first time a legal, semi-legal, or we use the boundaries of legal issues about drug prevention, drug use, to test this efficacy, because it's a WHO and ICMR joint project. We had certain legitimacy to implement a project. And this project is about distributing syringe, needle, clean syringe, needle, and distilled water along with bleach. So this is a package is distributed to the drug users. Only one condition that they had to come to the ICMR center to collect it. They can get it free. No questions asked. So we may ask, would you like to go for a consultation, counseling, or would you like to be referred to a treatment center? This is a very basic questions are asked, and without no other question, it is distributed. Then we look at the efficacy, how it is contributed towards reduction in HIV-related, the explosion. The HIV infection among the injection drug users was one of the highest in the country, was in Manipur, and particularly targeted towards, particularly experienced by 2 or 3 ethnic communities. But that ethnographic dimension of HIV infection is not highlighted in the national debate, national discourse. Now we think that HIV infection is under control, and talking about the history of a public health response towards HIV using harm reduction strategies. And this is how we created evidence for and advocating for a policy for harm reduction. And by end of my presentation, I'll also narrate some of the stories of the negative aspects of harm reduction, because that's important to learn that how we learn lessons from harm reduction strategies when you talk about implementing harm reduction in other contexts. And again, why do we remember that harm reduction is a set of practical strategies. And these practical strategies are evolving strategies based on experience and based on the implementation strategies. And if I switch my experience from Manipur to in Australia, in the Northern Territory, a city called Darwin, I was a regional manager for Northern Territory AIDS and Hepatitis Council. And there, no questions asked, they can come to the clinic and they can just collect injection drug paraphernalia. And also there is a space, what we call it as safe injecting space. They can come, bring their material, they can inject it under supervision, quote unquote, of professionals. So this other extreme of that. That's I managed another 2 years. So that I've seen the legal issues of her. And if you travel to Europe, very discreetly, some places you can see some unmarked vehicles are parked and people walk in and you can walk out, particularly when you travel to Geneva, just outside the Corneva train station. That's one of the main stations. There is two major trucks of stationery. And uninitiated visitor, you don't see anything in particular about it. You walk in, you can even get the pure heroin from to get injection. And also you can get methadone if you want to sustain it. There are some other alternative material for substance use you can get in. So why I narrated these stories is to show the complexity and the complexity in which how this is implemented in different contexts. And the modalities of the implementation is getting refined and it is legalized. Legal, quote unquote. When I say legalized means the legal aspects of harm reduction is also evolving. So this is another point you have to remember that. And when you look at harm reduction as a philosophy, it refers to a range of practices reducing policies reducing the harm, not necessarily to stop the use. So this is also important thing. And this is the emphasis on the human behavior and whether we can modify a little bit to reduce the harm. So this is a major aspect of the harm reduction. And this creates ethical and moral dilemmas. So this is one of the major, the reason for why this debates like this is being conducted, to explore what are the moral issues, what are the ethical issues, which should be addressed to implement it. Because this is also part of the legal provision, how law is evolving. And I understand that the idea of harm reduction from public health is more to very many other aspects. So for example, tobacco control is just being discussed. And also in the food industry, it is being discussed, greatly discussed. And even the sports industry now, we are talking about harm reduction for some of the what you call the contact sports, to what extent we can allow certain, the close contact, the punch, how strong or less strong, those kind of discussion. So what I'm saying is that the concept of harm reduction is spread out into various dimensions of human life. And again, the principle behind harm reduction is acceptance of the fact that some drug users cannot be, you cannot expect them to stop their drug use in the present condition. So this is the one of the revelation or understanding that drug use is not going to be completely eliminated. Then how do you deal with it? So this is the basic principle behind it. And also, again, let me emphasize that the focus is on preventing the harm rather than preventing the use itself. This also got another issue. I mean, we quite often we hear about a slogan called war on drugs. And the war on drugs, what we're noticing is that invariably it is war on drug users. So any country, if you look at it, whichever country when you use the word war on drugs, the war is on drug users. Again, let me just use this minute, 1 second, to highlight some of the word they use to explain certain issues. We use the word war, we use the word combating, and we also defending. So sometimes when you look at the language you use is militaristic language. From the public health, militaristic language is not we encourage to describe public health challenges and also public health opportunities. This is very important, the language when you use the drug use. War on drugs is invariably war on drug users. Drug users are the lowest link of the entire industry of drugs, drug use, drug smuggling, drug industry. But they are not the main kingpin who are making money out of it. The drug users, when you look at, they are the lowest, weakest link of the entire social phenomenon. And the language is in that context become very important. Any language, militaristic, when we invoke the ideas of militaristic ideas to look at public health, it invariably backfires. So those who are looking at harm reduction, keep this in mind. your language you use to describe substance use, drug use, even the tobacco use, this is not a militaristic context, a militaristic jargon you have to invoke to look at it. And this is another message when you look at harm reduction. We should be careful about the language use, even our day-to-day use when you describe about tobacco use and also drug use. Again, I emphasize this issue much more clearly. The moment we invoke the imagery from militaristic imagery, that invariably lead towards focusing on the drug users or the users of whatever subject we are trying to modify. And again, when you look at harm reduction, we aim to reduce the negative consequences. And if I may list some of the activities, one is a syringe access, syringe exchange from the drug use I mentioned, and also the distribution of naloxone, that is a medicine used for the overdose. In the United States, one of the major reasons for mortality related to the drug use is overdose. In India also, overdose is one of the major reasons for why drug users the substance adulteration is reduced. The one who uses the last end, they may think that they're using the regular one, the adulterated one, but they get very pure form of drugs without adulteration. That leads towards overdose. So overdose reduction is a harm reduction. This also, if you look at apply in the tobacco use, this has got implication. So naloxone is a substance which is distributed. If an overdose comes, they can give an injection immediately. So that is one of the standard overdose reduction in many part of the world. But India, the use of naloxone is very controlled. It's a medically controlled substance. So publicly, it is not available that way. And the third is at supervised consumption sites. Means I mentioned about sorry. Some of the European countries, this supervised consumption sites are very popular. But India, supervised substance use centers are not existing. I mean, it's not allowed, it's not experimented at all. And the third is about safe supply of drugs, injection drug use needle, and also disposal of used needle. That's also another issue. It's related to harm reduction. In India, you can see that the used drugs and the needle and syringe is just thrown out. It may be just deposited in the general garbage. It's not deposited separately. In some other countries, you can see safe disposable boxes. In washrooms, you can see yellow boxes, which is very discreet, but it is to deposit your used syringe and needle. So disposal of the used equipment is also part of the harm reduction. And again, when I mentioned that needle exchange program, which in Manipur, we experimented it. That's the first time the government of India, ICMR, and also Ministry of Health explored the possibility of allowing drug use. I mean, so, allowing the use of syringe and needle exchange. Now in India, that program is running legally under the name called targeted intervention. They don't call it as needle and syringe exchange. It's called a targeted intervention under the National AIDS Control Organization. There is about, I think my understanding, the number may not be exactly correct, almost 160 districts there are syringe and needle exchange programs. But in the Indian context, we have noticed that how they modified that innovation, how you distribute syringe and needle. And I'm not naming the place. I've visited many other substance use harm reduction in the Indian context. In one district in the beach side, there are places you can see clean syringe and needle packets. They pack it and they keep it in some strategic location. And these are the places where the drug users come and congregate to inject. So, but in other countries, it is they have to come to the center and collect it. But the drug users' access to institutions are very, very limited because the institutions are actually, the Indian context represent the power structure. And also most of the drug users are, in essence, they are alienated, they're marginalized from the society. So any idea of encounter with an institution is frightening for them. So the Indian context, we deinstitutionalize the distribution of harm reduction activities. And this is mostly done by the peer outreach workers. These are the drug users or they're ex-drug users or some of them still using it. Under supervision of the social service or social workers, they distribute needle, they distribute syringe and needle, the equipments. So this is, and also sometime in some places we have seen that a needle is, a metal spoon is also given. The metal spoon is given to heat the drugs. The number for heroin, they take the water and they heat it for injecting it before the injection. So there are different practices is happening across the country. In India, some people, they inject on the veins, they inject on your neck, wherever they can see it. So the practice also varies. So the harm reduction strategy to link up them with the medical facility is one of the harm reduction strategies. And yeah, there are a lot of criticism. I mentioned about ethical and moral dilemmas about harm reduction. And one of the major criticism about harm reduction strategies are it is enabling harmful behavior. So this is one of the major challenge, ethical and behavioral challenge. You're enabling them. You're contributing towards drug use, and also you're not addressing the core issues. This is one of the major criticism. And second, they're talking about justice and fairness. This is one of the, again, in the context of developing countries, is it fair? Is it just to spend money on buying drugs, buying needle and syringe, and give it to a drug user? And don't you think you should use this money for maybe for other chronic disease and spend money on other prevention of the diseases rather than investing on the drug users? So this is a major a justice and fairness issue about promoting harm reduction, whether we should invest public money for promoting unsafe behavior of certain individuals. So these moral issues keep on taking place in many parts of the world and in India also. And also the second issue is about, the next issue is about individual right versus community rights. So where do you emphasize? If you emphasize the right of an individual to continue his harmful behavior, or a society's right to have a safety from that. So this issue again is still an ongoing dialogue. And also we look at the issue of effectiveness and evidence. What evidence we have to look at and to promote harm reduction strategies. And I mentioned that one of the first harm reduction legal project was I was managing it as from the ICMR, Indian Council of Medical Research. So that's the first the technical project we run to look at the efficacy. And as a person who managed it, I can see the plus and minus point of view. In public health, there is a very, I would say, a secret about public health is that when you report the data, quite often you report the success stories. You don't report the negative side of them. Most of the clinical research, I'm sorry, let me very mildly put it that way. The clinical research, I'm a editor-in-chief of one of the leading public health journal, Critical Public Health and Cogent Public Health. Normally, we publish the success stories. I mean, the last year I approved about 400 papers. None of the papers are the negative stories. No paper. What failed when you implemented the clinical research? What happened? What failure? Unfortunately, the failure is more important data and evidence to look at the policy framework, but that is never shared. This is one of the ethical challenges of research in the medical field. This has got implication in the harm reduction strategy as well. Let me narrate my story of the data management about negative side. This data, I was not allowed, I'm not saying I'm not allowed. I didn't attempt to publish this paper. So maybe that's the best way to do that. See, the package we distributed was syringe, needle, distilled water, and bleach. So this is what we distributed. Why bleach? If they have a syringe and needle, they wanted to reuse it, use the bleach to clean it. And the pictorial material we distribute along with that, it shows how do you clean your syringe. Three times in, 3 times out, using the bleach. And also we give the clean distilled water to mix your drugs, because what happened is that they used to mix the drugs with polluted water, and that led towards vein collapse, vein abscess. So to reduce that vein abscess, we give clean water and the bleach. But interestingly, both the same color. And when they get high, many of the instead of distilled water, they use the bleach to inject it. This protocol was approved by probably 10 layers and ethics review committees, and ICMR ethics review committee, WHO ethics review committee. And I was a fresh fellow and I was a senior research officer. I didn't know, I mean, I was implementing a project which is approved by all the layers of that. But I started seeing, because I had three senior research officers, the research fellows who are the medical doctors, fresh MBBS graduates. They started seeing the vein collapse. And we didn't know how to deal with it, and we reported that. I mean, then we didn't look at it. We started seeing high incidence of drug users reporting with the collapsed vein. The reason is that they injected the number for heroin with bleach and injected it. And I'm just giving an example about when you implement harm reduction, some of the unexpected consequence of that. And why I'm highlighting is that whenever we look at harm reduction strategies, there are our efficacy of the data is not that precise. Maybe we focus more on the plus point success stories. And the efficacy of this injection drug use needle exchange is extensively published in paper, but not the negative part of it. And we didn't even discuss publicly. Very few areas we even shared this data of negative side of not looking at the failure of the project. And I would emphasize when you look at the harm reduction program, we have to strive towards creating more evidence and data, and also looking at the data at the negative side of what fails to our harm reduction thing. And the final one is about the moral responsibility, and whether the moral responsibility of society is more than its individual's responsibility, and how do you look at individual's moral responsibility towards society, and should we promote that moral responsibility rather than promoting their behavior or facilitating that behavior. So this moral responsibility issue is also one of the major issue of our ongoing dialogue. And also when you look at, there are dilemmas of harm reduction, but at the same time, there are reasonable evidence to have evidence-informed policies to implement harm reduction strategies and various aspects of it. It may be on substance abuse, it may be on food industry, and increasingly on the tobacco industry, sports. There are very many aspects of our human life where behavior need to be modified, reduce personal harm as well as social harm. And this is an evolving subject. It's a complex subject. And our dialogue is on the strategies, methodology, and our way of implementing it, how we capture the data, and ongoing dialogue and debate on the moral and ethical complexities. But at the same time, as a person who practices harm reduction, I manage harm reduction in various contexts in various countries. And one thing is we have ample evidence to say that harm reduction saves lives. So that saving life from that point of view, harm reduction works. Thank you.